Yeah. I'm going to talk a little bit about Ebola virus. It's absolutely fascinating, and one of the scarier viruses that we deal with is part of the tropical viral hemorrhagic fever syndromes. Let me just begin by telling a little bit of story about Ebola. So this is the Ebola River. This is the Ebola River from which the name derives from this syndrome. As you can see, it's a difficult place to get to, and it's part of if you read Joseph Conrad's novel *The Heart of Darkness*. This is the heart of darkness. This is central sub-Saharan Africa, difficult to get to because it's in the middle of a tropical rainforest, and the main mode of transportation in this area is actually through dugout canoes, and it's a tributary off the Congo River. It's sometimes known as the Zairian River, now more recently now the Congo River again. But you can see where this type of illness could have hidden in the bush for a long period of time, and probably did, until things changed in the mid-1970s. So in the 1970s, a tremendous evolutionary engineering advance took place, which is the building of the Kinshasa Highway. The Kinshasa Highway is a highway that takes goods and services from Kinshasa, Zaire, on the west coast of Africa, and goes to Nairobi. This goes through several different countries, through very difficult terrain and so on. So it was a major feat that was accomplished in 1975. And like many things of this nature, there were good things about it and bad things about it. What the good things about it was opened up transport and commerce to Central Africa and prevented ships from having to go down to the Cape Hope in South Africa to go to the other side of the continent. So it did increase commerce, which was good, an exchange of peoples and ideas, and which was all good. The trouble is it also opened up an area that previously was relatively protected from humans to an area now which is being infected by humans, and the humans are getting infections themselves when they go there. As you may know, it's been referred to as the Highway of AIDS, because through the seroarchaeology of the AIDS epidemic, you can trace the spread of HIV throughout the world actually to this highway. And you may know the story. The story is that when they built the Kinshasa Highway, truckers from the area would take loads and travel a couple thousand miles from one end of the Kinshasa Highway to the other. And the custom for some of the groups that had the trucking company was that men were not supposed to sleep alone at night, which is fine if you're married living in the middle of Central Africa, but if you're in a truck 600 or 6,000 miles away from your spouse, that was a problem. So they set up comfort stations along the Kinshasa Highway, housed by what were considered comfort women, or women who didn't think of themselves as prostitutes, thought of themselves as transportation workers, thought as part of this enterprise. The enterprise is to help the truckers make the long trek and provide a warm, comfortable bed for them at night. Unfortunately, someone with HIV got on the truck and drove down this highway and infected these women with HIV virus, and other truckers picked it up, and then when they went back home, they brought it to their spouses, and so on and so forth. So it's a famous highway for lots of reasons, but that's one of the more infamous reasons that I point this out. Now, it turns out this is a pothole in the Kinshasa Highway. And as you can see, they can have pretty impressive potholes there. We complain about it here in Pawtucket, at least I do, but it's nowhere near what you're going to see in Central African Republic, where you'll see whole trucks and their goods will disappear into one of these potholes. So it's difficult to maintain. There's been difficulty with security. People would get roadblocks be set up, and people would be kidnapped, and so on and so forth. It's not something you want to do on a Saturday afternoon, perhaps, but it was important from a economic perspective and from a transportation perspective. Now, it turns out that the following year, after the completion of the Kinshasa Highway, and this may have been serendipity, but it turns out the first recognized outbreak of a Ebola virus in the world, and the virus was first recognized in 1976, and it caused a pretty substantial outbreak. And the outbreak, as you probably, well, let's see if I can. Anyway, the outbreak was in Zaire and Sudan, and it was a pretty substantial outbreak with very high mortality, which is a pretty scary story, and then it disappeared. So like many of these tropical hemorrhagic viruses, they'll cause a big outbreak, it'll be horrendous for a short period of time, and then it disappears just as fast as it came. And it disappeared actually for almost 20 years. So the next really significant outbreak was in 1995, and this is the Kitquit outbreak, which was a pretty substantial outbreak and caused major problems primarily in Zaire. And then subsequently there have been, every few years there'll be another outbreak until the most recent outbreak, which is occurring right now in Western Africa. So, to the degree to which the Kinshasa Highway contributed to the spread of Ebola virus is conjectural at present, and that some people will debate this point, but certainly the timing was right. And if you look at the route of the Kinshasa Highway and the places where Ebola has been discovered, you can understand why people think of it maybe as a highway of AIDS and also the highway of hemorrhagic fever. So now talking about the current outbreak in West Africa. So the current outbreak is the largest outbreak in history, and probably it's been underreported. So there's probably more cases than is officially recorded, but the official document from the WHO as of this weekend had it that there were a total of 1,145 deaths and 2,127 confirmed cases, giving it a mortality rate of 54%. As you can see, both the cases and the fatalities are on the upswing. So the epidemic curve has yet to crest at this point, and it's not clear when that will be so. The recent predictions from a population epidemiologist suggest this may go on for another 6 months or so before it goes away. But time will tell. We'll see how that plays out. So here's where the outbreak is currently primarily located. It's in 3 countries in the west coast of Africa: Guinea, Sierra Leone, and Liberia. There you can see in the colored area there, the tan colored areas where they've had cases. So it's found not just in the cities and not just along the coast, but also substantial problems inland in difficult areas to reach, and areas where the data may not be as accurate as we think as far as how many cases there are. So Nigeria gets in the act because of a Liberian infected individual who got in a plane and flew to Nigeria and then became more ill, sought medical attention in Nigeria, and eventually died, and in the process he infected a number of healthcare workers who then had secondary and tertiary cases. So that's the current situation from a epidemiologic perspective. Now just a word about the virus. So the virus is a very interesting virus. So the Ebola virus is one of the filoviruses, or the thread viruses, in which there are 2 genera, the Ebola virus and Marburg virus. I'm not going to talk about Marburg virus, but just only to point out that Marburg virus, you may remember or have heard, is a similar hemorrhagic fever virus that was first recognized in Marburg, Germany at the university in Marburg, Germany, where they were studying some green monkeys, African green monkeys, who unfortunately happened to be infected with Marburg virus. They took them to Germany. They did some experiments on them, and the animals subsequently died. And the healthcare, or the vet that was taking care of them, and the healthcare workers who were taking care of the animals also developed an acute severe illness, a number of whom died. And then the nurses and doctors who took care of those people also died from a hemorrhagic fever. Then it stopped. And it was a very scary situation. This was in 1967, and then it disappeared. And nobody heard about that virus for another 30 years. And now we're seeing a circulation of Marburg virus as well. So they are interesting viruses. One thing to point out is that there are 4 different species of Marburg virus and 5 different species of Ebola virus. And they're not as closely associated as you would think. I mean, they're from a virologic perspective, they're related, but antigenic differences are pretty substantial. For example, antibodies directed against Marburg virus does not give you any protection against Ebola, and vice versa. And even different strains or species of Ebola are not very protective and don't bind very well to the other viruses. So the incident mortality rate also is strikingly different depending on what strain or species you're dealing with. So in this figure, you'll see, or maybe you can see that if you have the Zairian strain, the overall mortality over the last 40 years is about 80%. If it's the Sudan strain, it's about 50%, 50 to 60%. So the mortality rate is a little more like the Sudan strain, even though virologically it's the Zairian strain. There is a strain that was found in Uganda, which is still circulating in Uganda at times, the Bundibugyo strain, which has got a low mortality of 27%. And then there's another strain that even in humans has a very low mortality, basically 0, which is from Côte d'Ivoire, or the Ivory Coast, and transmits between humans but doesn't cause disease, or at least much of a disease. The same is true with the Reston strain. So the Reston strain was first isolated in Reston, Virginia, and was a big scare because this is a suburb of Washington, D.C., and a very urban population. And at a primate research center, they had an epidemic there, which was quite interesting. It was lethal to the subhuman primates, but the workers who worked there, almost everybody wound up getting infected, but no clinical illness. It was just a serologic findings, which is good news for them, of course. But it was also a bit scary because in that outbreak, it was very well documented that transmission via non-contact with the animals or their secretions could potentially be transmitted by the airborne route. Now, exactly what form that took is a little difficult to say, but there were clearly humans in that situation who had no exposure to the animals or no exposure to the excreta of the animals, who but shared atmosphere through the vents. They shared vents, but they were in different offices and weren't really interacting with the animals, who wound up getting seroconverting, indicating that it's at least possible for some Ebola viruses to be transmitted by aerosol. And that's a scary possibility. I mean, it's bad enough to think about transmission that we think is the primary mechanism of transmission now, but if it was airborne, it would really be a catastrophic situation. And that does not appear to be the case at the present time for the current outbreak or previous outbreaks between human beings. So the other big mystery with the filoviruses is what happens between epidemics. Where do they go? How do they survive? And what is the animal reservoir? When they initially did the initial workup, I happen to remember this because I was a fellow at Walter Reed where they were doing a lot of this work, and C.J. Peters was interacting with the biodefense group there in Washington, and they spent a lot of time in this outbreak, the first outbreak, collecting samples from trees and insects and worms, everything they get their hands on to try to figure out where this virus was living, what was a reservoir. And they sampled a number of bats. They worried about bats. They sampled bats, and they all struck out. It has subsequently been shown that the reservoir actually is bats. This is the African fruit bat. Sort of a scary-looking animal, but they're herbivores. They're not vampire bats and stuff like that. But bats are amazing creatures. They are serologically and immunologically very capable. And as you know, they can carry rabies for months and not get clinically ill. They eventually do get clinically ill, but they tolerate pretty nasty viruses for a long period of time, and that's true here. So it's now very clear that both for Marburg as well as Ebola, that it looks like it's the African fruit bat is the reservoir. And may at times be the vector. It's possible that introduction into human populations actually occurs from the bats. So the enzootic cycle that occurs in nature in the African rainforest is primarily between bats, and maybe between bats and some ungulates that live in the tropical rainforest. And then it had been thought that maybe old world apes, such as chimps and gorillas, may be a reservoir as well. It turns out that's actually not the case. They are very susceptible, just like humans are, to Ebola virus, and they're having a devastating effect on the natural population, particularly of chimpanzees, actually. And so they're not a natural reservoir. They're an unnatural host, and they tolerate very poorly and die just as much as humans do. So what makes it the scariest for us is that human-human transmission definitely occurs. And so when the virus winds up in a human, makes a species leap into humans, they do poorly, but they're also highly infectious to others. So this is what the virus looks like. They're called thread viruses because they're very long, skinny viruses. They're single negative strand RNA virus with a fairly plastic genome. So there's a lot of differences from one strain to another, very much like HIV. You know, if you've got a single strand RNA genome, you don't have that editing function that DNA provides, and so point mutations occur very quickly. And it's probably important in the lifespan of the virus to constantly be changing its antigenic constituents to allow it to exist in nature. So the primary virulence factor and primary immunodominant epitope of the virus is a 125 kD transmembrane spiked glycopeptide that's found on the surface of the virus, to which antibodies can be generated, and if done correctly, may actually be protective. There's another large polymerase antigenic molecule, as well as a nucleocapsid and a matrix protein. There's some evidence that the virus will actually release soluble transmembrane glycoprotein, perhaps to bind to antibodies to be a smokescreen around the virus to allow it to survive even in someone who's got antibodies. Now, the virus primarily infects monocytes, macrophages, dendritic cell population, but will also directly infect endothelial cells. So for the most part, it's inside monocytes, and it will infect and kill monocytes. In the process of doing so, they will release pro-inflammatory cytokines, which are measurable in the circulation, but not that striking. But you'll be able to find TNF and IL-6 and IL-8 and IL-1 alpha and IL-1 beta because of lethality to monocytes. And in the process of doing so, it activates endothelial cells. Activated endothelial cells then become susceptible to infection with the virus. The virus actually is taken up by endothelial cells, by receptor-mediated endocytosis, and will eventually kill endothelial cells and cause them to round up, and the barrier between one endothelial cell and another will be relaxed, allowing for translocation of serum proteins into the interstitial spaces, and hypotension, vascular instability, and septic shock and death. So that's basically what happens when people get infected. The symptoms are relatively nonspecific, and so they don't differ terribly from other viral hemorrhagic fevers or other common illnesses in the area. So there's a story about in Sierra Leone where the doctors, because of the fears about these, would do an orange juice test. So you may have heard this, where somebody comes in the emergency room with an illness that looks like it could be a tropical viral hemorrhagic fever. They say, well, we have a special place for you. You go to this building over there, and you go to this building. It's basically a shed with a lock on, so you get locked inside there. And then they would bring orange juice once a day, see if anybody was still alive to pick up the orange juice. And if people kept drinking the orange juice, they'd say, geez, maybe you've got something else. So they'd take them out, and they'd turn out they had malaria or typhoid or something else. So I wouldn't recommend that, but you can understand the fear that occurs from this situation, because one of the major sources of patients are actually healthcare workers. So that's what makes it a scary virus. And the way it presents is often relatively nondescript systemic symptomatology with headache and fever. The red eyes or the blood coming from the eye is something that people talk about, but it's actually relatively uncommon. But they get subconjunctival hemorrhages, and it gives them the redness of the eye. They'll get a pharyngitis. They typically will get skin lesions, which are quite characteristic. They'll get a maculopapular skin eruption in the truncal area, which then may become hemorrhagic, which helps to distinguish it from other viral hemorrhagic fevers. The other thing is they get myalgia, general malaise, weakness, abdominal pain, vomiting, diarrhea is a big problem. If you do the lab shows early and very profound lymphopenia. So it looks like the virus actually induces profound changes in the trafficking of lymphocytes early on from the vascular tree into the extravascular space, into the lymph nodes. So some is due to apoptosis, and most of it is trafficking of lymphocytes outside the circulation into the reticular endothelial system. They also will develop severe thrombocytopenia and develop classic DIC with marked thrombocytopenia and fibrin split products and prothrombin fragment F1.2 and TAT complexes, the whole line here. So typical DIC-like picture, but combined with a synthetic problem. So they have not only consumptive coagulopathy, but they also have a synthetic coagulopathy and hepatic coagulopathy because the liver is affected early on and they stop producing clotting factors. So this is a major problem for the patient and gives them the hemorrhagic manifestations. The other characteristic finding is the AST-ALT ratio, so they get a striking elevation of aspartate transaminases as opposed to alanine transaminases. This can be used as a diagnostic test. The ratio is usually a very substantial difference. If you measure cytokines, they'll be elevated as well. So the diagnosis is usually made by PCR or a immunohistochemistry assay of the skin biopsy. There's a pretty good antibody or antigen capture ELISA serology, but it may take a while for that antibody to show up. So it's usually you look for the virus itself through PCR if the opportunity is available to you. Death is usually caused by refractory shock, disseminated intravascular coagulation, GI bleeding, and AKI. They usually don't develop ARDS, interestingly enough. So the lungs are relatively spared unless they have pulmonary hemorrhage. So the CDC definition for Ebola virus is as follows. So what if somebody showed up in the emergency room this afternoon? I got a call a few minutes ago from the ER about a patient who's just returned from Liberia with X, Y, and Z. And I go, oh my God, this would be perfect for the lecture I'm going to give. No, but turns out the patient had left there 6 months ago, left Liberia 6 months ago, and lived in Missouri for a while, and just recently showed up here in Rhode Island. Anyway, so I don't think it's Ebola. But the long and the short of it is the way you should, the CDC case definition criteria, at least at present, is that patients who are, or persons who have traveled to a endemic area for the current outbreak, which is Guinea, Sierra Leone, Liberia, or Nigeria, within the past 3 weeks, who was either in contact of a patient or a family member with Ebola virus. Possible would be someone who has symptoms, who've been in the endemic area the last 21 days, and confirmed would be someone who has a positive diagnostic assay, PCR, or antigen capture ELISA. So this is making morning rounds these days in Liberia, and this is symptomatic of the difficulty these doctors are facing in Liberia. So, notice it's an open air environment, right? So the patients are not in ICUs with lots of fancy equipment and so on and so forth. They're laying on a cot in these open air environments like this, and the doctors have to do what they can to protect themselves. In this picture, you'll see the resident there has got a mister that he would go into the room, and he sort of squirts this mist of Clorox in the patient's face before they examine the patient. It's actually not recommended to do that. There's no clear evidence that it has any value, but people will still do it. You also notice they're wearing booties, which is a good idea. They're wearing fluid impervious gloves that they're having to work with, and they're trying to protect the mucous membranes as best they can as well. So what's the transmission risk? Well, it's important to talk about this because a major risk for transmission is actually healthcare workers. Family members, of course, pathologists, laboratory personnel are at great risk. Morticians and funeral attendees are also at risk. So people need to know this. And the virus is primarily transmitted by direct contact with infected individuals, their secretions or excretions or fomites. So that's the primary way of transmission. That's why doctors and nurses get involved, because they're directly taking care of these patients, and why family members are at risk as well. So the virus replicates, as I mentioned, in monocytes, macrophages, and endothelial cells, and will generate enormous viral loads. So the secretions of these patients are highly infectious. They'll have 10 to the 9, 10 to the 10th virions per ml, highly infectious. And that's why lab people and people who have used medical sharps are really at great risk with this virus. And it's not just found in their blood, it's also found in their urine, it's found in their saliva, it's found in their semen, it's found in stool, vomitus, any secretion or excretions from a patient is potential concern. And lastly, but not least, is perspiration. So it'll coat the patient's skin because they'll be sweating because they're having fever in a hot environment, and the perspiration is highly infectious. So it's one reason why people who are going to funerals and preparing the body or going through religious ceremonies with their dead loved ones wind up getting infected, because they're touching the skin and kissing the person and whatever, and in the process of doing so are infecting themselves. So it's important that people not do that. And it's important that as healthcare workers, we protect ourselves and our colleagues as best we can in caring for these patients. So I mentioned a little bit about airborne transmission. There's very little evidence epidemiologically that the Zairian strain that is the current archetype that we're dealing with is transmitted significantly by aerosol. However, certainly as healthcare workers, we want to protect our mucous membranes when we're doing situations that would induce sputum or saliva or things of that nature, or any kind of procedure. So you want to protect your mucous membrane. So the current thinking is that physicians should wear protective equipment that would be contact isolation par excellence without messing around, and protecting your mucous membranes for droplet nuclei primarily. So that's the recommendation. Now, some people are of the opinion that maybe we should go a little step farther. Maybe it really ought to be more like airborne precautions rather than droplet precautions. But if I can tell you, for the most part, in country where the epidemic is, it's being handled primarily by droplet precautions. Sir.
Any chance the skin is a portal of entry, or could be?
Yeah, probably so. I mean, probably that's a frequent cause of entry. So it's not just needle sticks, right? So if someone bleeds on you or coughs on you, you're at risk. And what you're supposed to do in that situation is, just like if you've gotten a needle stick, you're supposed to stop whatever you're doing, immediately seek attention for yourself, and clean off the area, and go with alcohol or Clorox on the area. So yeah, so it's not just broken skin with needles, it's also unbroken skin. So also it's pointed out, the lab people are really at risk, right? So it's terribly inconsiderate of you to be wearing a biological warfare unit, and then the people in the lab don't even know that there's a patient like this, and they're handling it on an open bench. So it's very important that there's a transmission of information to your colleagues in the laboratory to make sure that they're aware about this. Now, they can limit the risk substantially. There are things they can do to the blood, urine, and tissue to protect themselves, but they need to know that those things should be done, and so that's part of your job, is to notify the lab about the situation. Basically, reusable medical equipment shouldn't be used in these patients. It should be one-time use only, and we'll talk a little bit about more infection control things next. So first and foremost is, if you have a patient, if you're seeing somebody in the ER that you are worried about, the first thing you should do is actually get a hold of infection control. This is what the infection control service is here for, right? This is what they've been trained for, and waiting all their life to get that call from a house officer. They've got a case, so give us a call for sure. And hopefully things will flow from there. So as I mentioned, basically apply maximum contact isolation. And for the most part, if it was me, I would personally wear a personal protective self-contained ventilator face shield that we'll show you in a few minutes. N95 mask as opposed to a surgical tie mask. You probably ought to wear an N95. At least I think I would go for that. But probably a plain old surgical mask is better than anything. At least it protects your mucous membranes. It should cover your eyes as well. So you should wear goggles or have a face mask when you're caring for these patients. You should use a fluid impervious gown, boots if you're going to be doing some major lifting of the patient or dealing with medical waste. And again, you should obviously double bag all the medical waste and notify the lab and pathology of what's going on. The Department of Health needs to be notified. The CDC needs to be notified. They will fly up here in a minute when the first case shows up, so make sure you make those contacts. But again, the infection control service will help you out with this. The patient should be put in. I used to recommend that these patients be kept on the ground floor near a window so that the portable van could come up and link into it. And they decided it doesn't work that well, and it wouldn't work here in our hospital either. So you're better off just putting them in the best isolation room. So 557 and 657 in the hospitals, those rooms where you have a little ante room, you walk in, there's a door, double door, those rooms. There's two of them that are the best rooms in the hospital for this, and the air exchange ratio in those rooms are better than the operating room. So I mean, those are great isolation rooms if you close the door. Okay, so that's why there's two doors there, right? You walk in one door, you close the door, you walk to another door, you close that door. And there's a gauge over the door that tell you whether you've done the right thing. It's disheartening when I'm walking down the corridor and I see both those doors wide open and the window open and air blowing through the hospital from those rooms. So don't do that, okay? So those are special rooms with a special airflow designed specifically to take care of patients like that. You put them in these rooms, they should have limited / maybe better no visitors, right? The visitors are putting themselves at enormous risk and often are not aware of the risk they're taking. So better to have no visitors or maybe one visitor who knows the risk they're taking. And if they feel obliged to come in and say hello, they should stay. It's recommended they stay at least 5 meters away from the patient. They can wave, you know, but not recommended. But in times of severe need, maybe so. You want to document who entered the room, and you want to document which healthcare workers are involved in the care of the patient. And you want to limit that number as much as possible. So it's not a time to show your friends and the medical students, gee, let's go look at this great case of viral hemorrhagic fever. You know, you want to pay due attention to the situation. Okay, Clorox is recommended, so plain old bleach is still recommended as the best. The virus is rapidly killed by Clorox. It's killed by other things as well, but Clorox is thought to be the best. And the linens ought to be treated with Clorox before they get washed through the hot cycle. And as far as autopsies go, it's recommended don't do autopsies. Yes, they would be interesting, but they're a great risk, and there have been many pathologists, some famous pathologists who died doing autopsies on these patients from many nicks, cuts, and scratches in the autopsy table. So probably not do an autopsy, and when the patient succumbs, a body bag is brought up to the room, the patient's put in the body bag, zipped up, and cremated, if at all possible. Certainly here in the U.S. that would be possible. And that would be the safest thing to do. You want to wash down the remains before they're taken out of the room, and the patient should not leave the room if at all possible. Okay, so what's going on right now in Africa? The situation is tense, is very tense, and understandably tense. And you have to realize these are a population of people who have had a rough time. Their governments have been difficult to deal with, their life situation has been difficult to deal with, and they're quite suspicious of other people coming in and telling what to do, all of which are totally understandable. And you can understand the problem. So in the top left there is a quarantined family. So if a family is taking care of someone who winds up having Ebola virus, they're put in quarantine. They're not allowed to move around or get in a car and drive away. They're put in quarantine until such time as they're shown after 21 days to not have a clinical illness. People are not happy about that, and they have actually had to bring in their National Guard to provide that security because a number of people decided they didn't want to be in quarantine anymore. So it's a problem. This other group on the upper right hand of that figure is case finding. They're going around to villages, checking to see if anybody has any symptoms. So that you may notice the guy's got a sign talking about the various symptoms and signs of Ebola. And they're trying to make sure they capture anybody who might have Ebola hiding in homes of these patients. And they're pushing, on the bottom there, you see the guy washing his hands. They're pushing hand washing, hand hygiene, and personal protection to prevent cross-contamination and recommend appropriate protection for individuals and decreasing spread of disease. These are asymptomatic individuals. They're not ill. They're just they've had a family member who had it, so they just are keeping an eye on them basically. So they're not put in any kind of protective gear. Now, if somebody was in the hospital and had to go get a whatever test, you could definitely put them in protective gowns and so on and so forth. But in this situation, they're just contexts that are now put in isolation. And the same thing, washing your hands once a day in the middle of the street is probably not such a great thing to do. But if you don't have any running water in your house, it's better than nothing. So the idea is to try to talk about the simple things that can be done to decrease transmission. Now the treatment is really disappointing, right? So the treatment is supportive, which is better than nothing. So people who come to the hospital and get IV fluids and get blood if they have a major hemorrhage do better than if they stay at home. So I'm not trying to denigrate the value of supportive care. There is some value to supporting these patients. And that's basically what happens. They're given fluids, they're given Tylenol, blood if they need it. And that's pretty much it. Which is disappointing, right? That these viruses have been known for 40 years, but there's still no treatment. And not that people haven't tried, but they haven't tried that much, actually. So there is some experimental therapies that you're probably familiar with, one of which is this monoclonal antibody cocktail, 3 monoclonals directed against the 3 major immunodominant epitopes on the virus. The problem is it's very expensive. It can only be used to treat a few patients. And again, because the virus will mutate fairly frequently, developing a huge stockpile of this stuff and sitting in a tanker somewhere and then waiting 20 years to use it isn't going to help, because in 20 years the virus is going to change. So the monoclonal antibody is maybe good for a few patients, but it's not really going to be that effective. Similarly, the siRNA, there's a very effective treatment is using small inhibitory RNA directed against the RNA polymerase of the virus. The problem is it's very difficult to get the siRNA to the area in question where you're interested in getting all this infected cells. So it sounds like a good idea and it works in mice, but whether it would actually work in a human being is not clear, but it's something people are trying. People say, well, how about a vaccine? How about convalescent serum? Convalescent serum seems so logical that if somebody survived, if you could just take their serum and try it, and it's been tried, it really doesn't seem to work very well. Now, there's some evidence it might work if you get people later. So you can't get them 3 months after they've had infection. You have to get them 3 years. And it turns out there may be some antibody maturation that will allow IgG antibodies of people who've had Ebola a long time ago may actually be protective. But people are working on it. But I can tell you so far, it seems so logical, but it really hasn't worked very well. And neither has ribavirin. Ribavirin works against Lassa, but not against Ebola. So there's other adjuvant therapies people have talked about, and they're interesting and possible, but haven't really been studied. And we're going to try to get a study going as one of our faculty members is going to Liberia next month. We're going to try to get a study going from the Infectious Disease Service. I won't tell you who that person is, but it's not somebody from Memorial Hospital, but one of our colleagues. And so we're going to try to get a study going and see if we can do something for these patients, and probably with statins or ACE inhibitors, which have some salutary effects that might work, but the big advantage is they're available in country and they're generic, so they're very low cost, available, well-known, safety records very good. And the idea would be to see if we can get the local physicians interested in doing this. It's not like the problem here, which is the cartoon says this one works great, but none of the rats can afford it. That unfortunately is true for Ebola in West Africa as well. Giving a monoclonal antibody in a situation like this is questionable ethics, actually. And the ethics is related to a pejorative term referred to as safari medicine. Safari medicine is when ivory tower doctors in Europe or the United States doing research on poor people in Africa with drugs that the actual patients couldn't possibly afford and will never receive when the study's over. So these people feel put out by having doctors do experiments on them with very expensive drugs that they would never be able to use anyway. and that is of questionable ethics, and it's something that the Africans and other people in developing countries have riled against about our seemingly good-natured attempt to help them out doesn't necessarily go over so well, and they're rightfully suspicious about anybody who does studies on them when they haven't really thought about, is it possible that people could actually use it when they get done? And another reason why we think that it might be easier to get acceptance with something with drugs that are already available, that they are very inexpensive in country. So we'll see. I mean, I don't know how this is going to go, and I'm really concerned about what's going on there. And I have some friends who are there now working with a group that we have called SARIC. And it's quite scary what's going on in some place. In Nigeria, it looks like it's going to be controlled. In other West African countries, not so much. So we'll see. It's going to be something we're going to worry about, and something you should be at least aware about in case somebody shows up in the emergency room that has left an endemic area. So with that, I'm going to stop, but ask Trish or Aurora, you want to